Bioethics 2.0, Podcast Episode 14, Pediatrics.
There are a number of areas of ethical concern for pediatric patients. Here are just a few. The standards that parents and others as surrogate decision-makers use, the difficulty in establishing specific guidelines for newborn and pediatric ethical issues, the increasing capacity for decision-making that kids have with normal intellectual development, the dual responsibility of healthcare professionals who care for infants and children to their patients and to their patients' parents and families, the question of the moral standing of very young infants, and finally, the use of children in research and as sources of tissue and organs for other family members. This particular podcast is going to focus in on one specific issue, namely issues associated with newborn infants, and the reason for this is because these issues have led to the following: difficult ethical dilemmas associated with the high technology and medical care, quality of life issues, the authority of parents and others to make decisions for children, and what guidelines should be followed when making these decisions. For a bit of history, we have to go back to the baby doe regulations. The purpose of these regulations was to ensure that handicapped infants received all potentially efficacious, life-saving treatment without consideration of quality of life. The regulations appeared to require maximal treatment in all cases except those in which treatment was futile because the infant was irreversibly and imminently dying. There were hotlines set up for people to call and make reports, and baby doe squads would descend on NICUs and other units of the hospital. During the baby doe regulation period, physicians and other clinicians were the ones who were mainly responsible for making decisions on behalf of children. That approach has changed. The focus is now on what standards parents and families should use to determine the best interest for their children and make decisions accordingly. Some may ask, well, why the change to parents and families? And there are a variety of reasons for this shift. First, parents and families are in a unique position to determine the moral status of the infant. Do they consider it a wanted, quote-unquote, person? Parents are also generally most knowledgeable and interested in their children and most likely to do the best job for them. Most importantly, the family bears the consequences of the decisions that are made. And finally, children learn values and standards within their families, and these values and standards may lead to different healthcare choices. There have been criteria that have been put forth to help decision makers. The first is, decision makers should have relevant knowledge and information about the medical facts, the prognosis, and how the family is operating. The second is that the decision makers try to the best of their ability to be impartial. The third criterion requires emotional stability in decision making. And the fourth concerns consistency. The process used to make decisions should end with the same result in similar cases. I personally have a bit of problem with a couple of these criteria, especially if we're going to be relying on parents and families to be the decision makers. Look at numbers 2 and 3. Impartiality, emotional stability, and in some cases, number 4, consistency. How is it possible for a family to be impartial when making a decision about a member of their own family? Emotional stability. How is it possible for parents and families to be emotionally stable at a time of crisis when they have to make decisions for a very young infant? And consistency. How can we expect parents and families to make consistent decisions or decisions that would be consistent with other cases when the uniqueness of their own family situation is what we're asking them to take into account? The upshot of all this is that the parent's decision should benefit the well-being of the child. Given the problems that I've put forth with the criteria for decision-making, the most realistic and functional approach to decision-making about treatment of imperiled newborns is similar to the approach that we have talked about in the previous set of podcasts. That involves shared decision-making, a shared process that involves surrogates, mainly the parents, and the clinicians involved in the infant's care. Given that we're looking at shared decision-making with imperiled newborns, there are different roles that each party can have in the decision-making process. For instance, clinicians have a separate role from that of the parents. The clinician's role should be to diagnose the infant's condition, and they should seek consultation as needed, present that diagnosis to the patient's family, provide a prognosis, discuss the options for treatment, make recommendations where appropriate to the family, and engage in a process of communication and disclosure that should provide the family insight into all of the issues involved in the child's care. The family's role is to bring their values, goals, and preferences to the discussion. These should be realistic in terms of the information provided by the clinicians. And ideally, with all of this information and each of these roles being separated, a decision can be reached. Despite the ideal of this shared decision-making process, there are 4 problems that remain. The first is quality of life. The second is defining best interests. The third is economic factors. And the fourth is clinical uncertainty regarding children's prognoses. The reason why quality of life remains a problem is because defining it precisely depends on one's perspectives, life experiences, and values and beliefs. There is a minimal condition, however, for defining quality of life: the capacity for experience or social interrelating. Therefore, if the condition is not met, such as if we have an anencephalic, treatment is not required. Another definition that's been put forth concerns 3 components. Number 1, freedom from intractable pain and suffering, the capacity to experience and enjoy life, and an expectation of continued life. Defining best interests also depends on a very subjective assessment. However, the information we're going to provide should provide a more objective approach. Best interests can be further separated into 2 categories, that being current interests, meaning short-term interests, and future-oriented or forward-looking interests, those that are more long-term in nature. It's important to remember that best interests should be framed from the perspective of the infant, not the family. 2 definitions have been put forward to help in defining these best interests. One is the converse of the 3 conditions that are necessary for minimal quality of life, namely, the inability to survive infancy, the inability to live without severe pain, and the inability to participate at least minimally in the human experience. Another definition has 8 variables for evaluating best interests. They are as follows: the severity of the patient's medical condition, the achievability of curative or corrective treatments, the important medical goals in the case, whether they be prolongation of life, relief of pain and suffering, or amelioration of disabling conditions, the presence of serious neurological impairments, the extent of the infant's suffering, the multiplicity of other serious medical problems, the life expectancy of the infant, and the proportionality of treatment-related benefits and burdens. Economic considerations also could be problematic. Other familial interests, such as avoiding depletion of family resources, should not be considered until a certain threshold is reached, namely, when significant patient interests would not be served by continued treatment or by particular treatments. The last problem concerns clinical uncertainty. The uncertainty here pertains to prognostication, especially in terms of gestational age, which may not be able to be precisely determined. The recommended approach is that of an individualized prognosis. Clinicians and families together have to decide for each infant, using the available data, the present condition, and a benefit-burden analysis, all together to make a decision that is in the best interests of the infant.